Doctors could prescribe houses to the homeless under radical Hawaii bill. Newly introduced bill would classify homelessness as a medical condition, as research suggests healthcare spending falls when people have been housed. By Liz Barney in Honolulu, Tuesday, 28 February 2017. One day last month, Stephen Williams asked a passerby for help and then collapsed on the sidewalk. When the ambulance arrived in downtown Honolulu, his temperature was well over 104 degrees Fahrenheit. A life-threatening infection had entered his bloodstream. Williams, who lives on the dusty streets of Chinatown, spent 7 days hooked to an IV treatment that can cost $40,000, according to the hospital that admitted him. But Williams didn't pay. The bill was covered by government dollars in the form of Medicaid. Over the past 4 years, he has been to the hospital for infections 21 times, he said, a consequence of flare-ups in a humid climate and unsanitary conditions. Cases such as these have prompted a groundbreaking new proposal in Hawaii. Instead of prescribing medication to homeless patients like Williams, what if doctors could prescribe something else that might make better, their health problems more effectively? The prescription would be housing. With this aim in mind, a state senator, Josh Green, has introduced a bill to classify homelessness as a medical condition. Green, who is also a physician, said the idea originated in his own work in the emergency room, where he saw many homeless patients arrive for treatment of basic conditions at great cost, but no real long-term benefit. Good thing. I'm just really applying a Band-Aid, he said of his medical work, but these problems require intensive, long-term support. A small number of homeless people require a disproportionate amount of medical treatment, according to Green. A recent study by a major Hawaiian insurer found that over half of the state's $2 billion Medicaid money was used by a tiny fraction amount of users, many of whom are dealing with homelessness, mental illness, and substance addiction. Yet researchers suggest that healthcare spending for those who have been homeless for long periods and struggle with mental illness and addictions falls by 43% after they have been housed and provided with support services. Green said many of the individuals he hopes to house cost the healthcare system an average of $120,000 annually, yet the annual cost to an individual is $18,000. He thinks that the total savings to the state could be hundreds of millions of dollars. As envisioned by Green, doctors could prescribe housing on a case-by-case basis. In order to qualify, the patient must have been homeless for at least 6 months and suffer from mental illness or substance addiction. We're already spending the money on homeless people. We're just paying for it in the most inefficient, expensive way possible, he argued. We have a lot of capacity, but lack the political will. But not everyone agrees that homes could be part of the solution. First, some people think that it is just too much. In testimony last month, the Hawaii Department of Human Resources Development, which oversees social services, suggested housing is beyond the healthcare system's remit and expertise. Second, there are concerns that such an approach might spread the state's resources too thinly. There is a population of homeless people for whom it is clearly a medical condition, the substance abusers and mentally ill, said Bob McDermott, a Republican lawmaker, was reported as saying last month. But other than that, it seems to be a stretch. Honolulu's largest homeless services provider agrees. You don't want to broaden it too much that everyone is eligible, said Kim Carvalho, a spokesman for the Institute for Human Services. A third concern is people walking out of the housing you give them. If you give mentally ill people housing, 9 out of 10 will just walk away and go back outside, Carvalho said. He added that he thought the best use of Medicaid was targeted housing for people with specialized needs, such as mental health group homes or addiction recovery housing, because of the neediest clients targeted by Green's bill might refuse accommodation. Whatever the case, the bill seems like a no-brainer to some of those dealing with poorer health in hard circumstances. Williams, the man who suffered from the staph infection, rested his swollen legs on a brick outside the outskirts of Chinatown. "It is very clear to me," he said, "if I could get a place to stay, I wouldn't have to go to the hospital so often." Section 2. A prescription to treat homelessness in Boston is threatened. January 25, 2017, by Alistair Martin, MD, MPP. It was 3 a.m. and 3 degrees outside, and I was about to discharge Mike from our emergency department for the third time in less than 24 hours. "Doc, let me finish this episode," he said, his eyes glued to the TV in the ER waiting room. Mike was homeless, and this was our routine all winter last year, when it was too cold to sleep in shop doorways or the bridge under I-93. Many times he was drunk, and we monitored him until he was sober enough to be discharged. Other times he would fabricate medical issues that needed to be evaluated, excuses that kept him safe and warm, at least for a few hours. That morning he came in intoxicated. Another physician evaluated him for signs of injury. There were none. When he sobered up, he was discharged with a thick stack of papers detailing the dangers of alcohol abuse. Later that day, Mike came back in, complaining of pain in his foot. Another exam, another discharge. About 30 minutes later, I saw Mike amble in and park himself back in the chair from which he had just been discharged. This time it was pain in his knee. Mike didn't need emergent evaluation. He came in because it was freezing outside, the tea wasn't running, and the shelters were too far away. Last winter, our emergency department saw hundreds of patients like Mike. Boston's annual homeless count last January tallied 1,732 individuals in emergency shelters. Hundreds more slept on the street. The truth is that for folks like Mike, we are their de facto, in fact, shelter, a hotel with infinite vacancies. But patients like Mike put a real financial strain on the system. One recent analysis that tracked 35 of Boston's high utilizers like Mike found that they accounted for more than $3.6 million in costs at a major Boston hospital over just an 8-month period. What should be the role of emergency departments in caring for homeless patients with no emergent medical needs? Emergency departments nationwide don't have a good answer to this question, nor do emergency physicians have either the time or the training to wrestle with this question on a busy shift. Instead, we deal with the reality we're handed. How long can we keep him in this warm examining room until another patient needs it? How many shelters will I have to call until one tells me they have room? How do we get him to the shelter 4 miles away in sub-freezing temperatures? "Let me just rest here," Mike said when I offered to get him into a shelter that night. "I ain't going to be back for a while anyway." "Why is that?" I asked. "They're getting me a place in Dorchester," he said. Surprised, I asked how. "Hugh's program," he responded, eyes not budging from the TV screen. In 2001, Boston made a bold step to help patients like Mike. It created the High Utilizers of Emergency Services, HUES, to Home program. It supports homeless individuals who are habitual users of Boston's emergency services by providing them with case management, links to substance abuse, and mental health counseling, and most importantly, it connects them to a permanent housing. Hugh's to Home is working. For example, after receiving housing, one patient who had visited the ER 50 times the year before didn't go to the ER once in 10 months. Another patient suffering from alcohol abuse was housed in a single-room occupancy apartment for 9 months. His ER visits dropped 90 to 12. But too many remain unserved. Like many of the programs that care for the city's poor, disabled and frail elderly, Hughes to Home is in desperate need of expansion. It also, like many of the programs that serve these vulnerable populations, partly depends on Medicaid for funding or money. President Trump and House Speaker Paul Ryan have proposed giving states a block grant for Medicaid rather than using the current funding formula. This could mean a cut up to 1/3 of current Medicaid funding. That reduction would jeopardize programs that protect vulnerable patients, programs like Hughes to Home, which gave Mike a way to escape the cold and which also saves the system money. Now more than ever, we must be committed to putting patients over politics. Protecting Medicaid funding is one place to start.